My name is Javier Pinilla-Ibarz, and I'm a hematology oncologist at the head of the lymphoma section of the Moffitt Cancer Center in Tampa, Florida. Today I'm going to present information about BENDEKA, bendamustine hydrochloride, and a case study about a patient with chronic lymphocytic leukemia. This promotional program was developed by Teva Pharmaceuticals, and I presented on behalf of Teva. I have received compensation from Teva to make this presentation. The information I will be presenting is consistent with the full prescribing information from BENDEKA under applicable Food and Drug Administration regulations. Please see full prescribing information from BENDEKA available at this site. To begin this presentation, we will review the indication and some important safety information for BENDEKA.
BENDEKA bendamustine hydrochloride injection. Important safety information for HCPs. Indications. BENDEKA is indicated for the treatment of patients with chronic lymphocytic leukemia, CLL. Efficacy relative to first-line therapies other than chlorambucil has not been established. Important safety information. Contraindication. BENDEKA is contraindicated in patients with a known hypersensitivity, anaphylactic and anaphylactoid reactions to bendamustine, polyethylene glycol 400, propylene glycol, or monothioglycerol. Myelosuppression. Bendamustine hydrochloride caused severe myelosuppression, grade 3 to 4, in 98% of patients in the 2 NHL studies. 3 patients, 2%, died from myelosuppression-related adverse reactions. BENDEKA causes myelosuppression. Monitor leukocytes, platelets, hemoglobin, and neutrophils frequently. Myelosuppression may require dose delays and/or subsequent dose reductions if recovery to the recommended values has not occurred by the first day of the next scheduled cycle. Infections. Infection, including pneumonia, sepsis, septic shock, hepatitis, and death, has occurred. Patients with myelosuppression following treatment with BENDEKA are more susceptible to infections. Patients treated with BENDEKA are at risk for reactivation of infections, including but not limited to hepatitis B, cytomegalovirus, Mycobacterium tuberculosis, and herpes zoster. Patients should undergo appropriate monitoring, prophylaxis, and treatment measures prior to administration.
Bendamustine hydrochloride was studied in a randomized, open-label, parallel group, multicenter, phase 3 controlled clinical trial in 301 patients with treatment-naive CLL, BNET stage B or C. A total of 153 patients received 100 milligrams per meter square of bendamustine hydrochloride intravenously over 30 minutes on day 1 and 2 of a 28-day cycle, and 148 received 0.8 milligrams per kilo of chlorambucil orally on days 1 and 15 of a 28-day cycle. Some patients with a stable disease receive at least 3 cycles of bendamustine hydrochloride. The primary endpoint of this study were overall response rate and progression-free survival. During the study, patients with progressive disease or intolerable toxicity discontinued treatment. In terms of patient characteristics, the need to treat criteria in the study included hematopoietic insufficiency, B symptoms, rapidly progressive disease, risk of complication from bulky lymphadenopathy. Patient exclusion criteria included autoimmune hemolytic anemia, which is a complication of CLL, autoimmune thrombocytopenia, Richter syndrome, transformation to prolymphocytic leukemia. Overall, the baseline characteristics were similar between the 2 treatment groups. With that vital information in mind, let's move on to the efficacy data for BENDEKA. During the open-label study of progression-free survival, defined as a time from randomization to progression or death from any cause, bendamustine hydrochloride triple median PFS compared with chlorambucil, 18 months, 95% confidence interval, 11.7 to 23.5 versus 6 months, 95% confidence intervals, 5.6 to 8.6, with a hazard ratio of 0.27 with 95% of confidence intervals, 0.17 to 0.43, and a p-value of less than 0.0001, showing statistical significance. Overall response rate was defined as a complete response plus nodular partial response plus partial response. Bendamustine hydrochloride delivered overall response rate that was more than double that of chlorambucil, 59% with 95% confidence interval, 51 to 66.6, versus 26%, 95% confidence interval, 18.6 to 32.7 respectively, with a p of less than 0.0001. 8% of patients with N equals 13 treated with bendamustine hydrochloride achieve a complete response compared with less than 1% of patients treated with chlorambucil. The slide presents the anaphylactic infusion reaction related to BENDEKA containing the important safety information.
Anaphylaxis and infusion reactions. Infusion reactions to bendamustine hydrochloride have occurred commonly in clinical trials. Symptoms include fever, chills, pruritus, and rash. In rare instances, severe anaphylactic and anaphylactoid reactions have occurred, particularly in the second and subsequent cycles of therapy. Monitor clinically and discontinue drug for severe, grade 3 to 4, reactions. Ask patients about symptoms suggestive of infusion reactions after their first cycle of therapy. Consider measures to prevent severe reactions, including antihistamines, antipyretics, and corticosteroids in subsequent cycles in patients who have experienced grade 1 or 2 infusion reactions. Tumor lysis syndrome. Tumor lysis syndrome associated with bendamustine hydrochloride has occurred. The onset tends to be within the first treatment cycle with bendamustine hydrochloride and without intervention may lead to acute renal failure and death. Preventive measures include vigorous hydration and close monitoring of blood chemistry, particularly potassium and uric acid levels. There may be an increased risk of severe skin toxicity when bendamustine hydrochloride and allopurinol are administered concomitantly.
Before moving on to our case study for this presentation, I would like to review some additional important safety information from BENDEKA related to the skin reaction and hepatotoxicity.
Skin reactions. Fatal and serious skin reactions have been reported with bendamustine hydrochloride and include toxic skin reactions, Stevens-Johnson syndrome, or SJS, toxic epidermal necrolysis, or TEN, and drug reaction with eosinophilia and systemic symptoms, or DRESS, bullous exanthema, and rash. Events occurred when bendamustine hydrochloride was given as a single agent and in combination with other anticancer agents or allopurinol. Where skin reactions occur, they may be progressive and increase in severity with further treatment. Monitor patients with skin reactions closely. If skin reactions are severe or progressive, withhold or discontinue BENDEKA. Hepatotoxicity. Fatal and serious cases of liver injury have been reported with bendamustine hydrochloride. Combination therapy, progressive disease, or reactivation of hepatitis B were confounding factors in some patients. Most cases were reported within the first 3 months of starting therapy. Monitor liver chemistry tests prior to and during BENDEKA therapy. Other malignancies. There are reports of premalignant and malignant diseases that have developed in patients who have been treated with bendamustine hydrochloride, including myelodysplastic syndrome, myeloproliferative disorders, acute myeloid leukemia, and bronchial carcinoma. The association with bendamustine hydrochloride has not been determined. Extravasation injury. Bendamustine hydrochloride extravasations have been reported in post-marketing, resulting in hospitalizations from erythema, marked swelling, and pain. Assure good venous access prior to starting BENDEKA infusion and monitor the intravenous infusion site for redness, swelling, pain, infection, and necrosis during and after administration of BENDEKA.
Now let's review a hypothetical patient with CLL that may be representative of a patient in your practice. Our patient, Judy, is a 63-year-old woman in overall good health, fit, who presents with fatigue and painless swelling in the right axilla. She currently works full-time, is not taking any medication, and mentioned no major past medical history. Upon further questioning, Judy reports occasional night sweats and the nice early satiety. The physical examination revealed 2 axillary lymph nodes, 2 to 4 centimeters, and 1 cervical lymph node, 2 centimeters. Palpable spleen tip. Judy's World Health Organization performance status is 1. Laboratory test results for this patient show anemia, leukocytosis, an elevated absolute lymphocyte count, and elevated beta-2 microglobulin level. It is important to note that the platelet count is slightly under the normal range, but over 100,000 because the criteria for an incomplete response for treatment per international workshop on CLL guidelines is less than 100,000 platelets or 10 grams per deciliters of hemoglobin. Judy harbors chromosomal deletion 11q. Positive staining is detected on testing for CD5, CD19, CD20-DIM, and CD23 in peripheral blood. Computed tomography scan reveals extensive lymphadenopathy in Judy's chest. Peripheral blood smear reveals lymphocytosis and smudge cell characteristics that are typical of CLL. Now, in order to properly diagnose and classify our patient, we can use the 2 relevant classification systems, the RAI and BINE classification system for CLL. Based on these criteria, Judy will be diagnosed with high-risk CLL. Per RAI classification, this patient will be categorized as stage 3 due to the presence of lymphocytosis, enlarged lymph nodes, and hemoglobin less than 11 grams per deciliters. BINE classification, stage C, for example, enlarged areas and hemoglobin less than 10 grams per deciliter. Given Judy's disease staging by the RAI and BINE classification, health status, and age, she's a good candidate for BENDEKA. Judy began treatment with BENDEKA injection, 100 milligrams per meter square administered intravenously over 10 minutes on day 1 and 2 of 28-day cycle for up to 6 cycles. Before concluding this presentation, we will review the dosing modification and consideration for BENDEKA. The following are the dose modification for BENDEKA for hematologic toxicity. For grade 3 or greater hematologic toxicity, reduce dose to 50 milligrams per meter square on day 1 and 2. If grade 3 or greater toxicity recur, reduce dose to 25 milligrams per meter square on day 1 and day 2. Dose re-escalation may be considered. The dose modification for non-hematologic toxicity include, for clinical significant grade 3 or greater non-hematological toxicity, reduce the dose to 50 milligrams per meter square on days 1 and 2 of each cycle. Dose re-escalation may be considered. The additional dosing consideration with the use of BENDEKA are as follows. Delay treatment for grade 4 hematologic toxicity or clinically significant grade 2 or greater non-hematological toxicity. Store BENDEKA at recommended refrigerated storage condition, 2 to 8 degrees Celsius or 36 to 46 degrees Fahrenheit. When refrigerated, the contents may partially freeze, so allow the vial to reach room temperature, 15 to 30 degrees Celsius or 59 to 86 degrees Fahrenheit, prior to use. BENDEKA should be diluted prior to the infusion. Additionally, concomitant CYP1A2 inducer of inhibitors have the potential to affect the exposure of bendamustine hydrochloride. Finally, we will review more important safety information.
Embryo-fetal toxicity. BENDEKA can cause fetal harm when administered to a pregnant woman. Conduct pregnancy testing prior to initiating treatment and advise pregnant women of the potential risk to a fetus. Advise females of reproductive potential to use an effective method of contraception during treatment with BENDEKA and for at least 6 months after the final dose, and males with female partners of reproductive potential to use effective contraception for at least 3 months after the final dose. BENDEKA may also impair fertility in males. Lactation. Advise patients that breastfeeding is not recommended during treatment with BENDEKA and for at least 1 week after the last dose. Most common adverse reactions. Adverse reactions, frequency greater than 5% during infusion and within 24 hours post-infusion, are nausea and fatigue. Most common adverse reactions for CLL, frequency greater than or equal to 15%, are anemia, thrombocytopenia, neutropenia, lymphopenia, leukopenia, hyperbilirubinemia, pyrexia, nausea, and vomiting. Please see full prescribing information for BENDEKA.
Thank you for joining us today. We hope you enjoy the resources of this site. For more information about BENDEKA, visit bendekaacp.com and please see full prescribing information available on this site.